He's just setting it up. You can see the slide, Dr. Girish?
Yeah,
Yes.
we can, yeah.
Yes.
Just minimize it. We can start now or we wait for some time?
We will wait few minutes, I think. Yeah.
ಇದು ಮಾಡಿದ್ರೆ ಆಗುತ್ತೆ ಅನ್ಸುತ್ತಲ್ಲ.
ಆಲ್ರೆಡಿ ಶೇರ್ ಆಗಿದೆ ಅವ್ರಿಗೆ, ಅದೇ ಪ್ರೆಸೆಂಟೇಷನ್ ಕಾಣ್ತಾ ಇರೋದು, ಈ ಸ್ಕ್ರೀನ್ ಕಾಣ್ತಾ ಇರೋದು ಅವ್ರಿಗೆ.
ಓಕೆ ಇದು
ಡಿಸ್ಕನೆಕ್ಟ್ ಆಗುತ್ತೆ ಪ್ರೆಸೆಂಟೇಷನ್, ಸ್ಕ್ರೀನ್ ಫುಲ್ ಡಿಸ್ಕನೆಕ್ಟ್ ಆಗುತ್ತೆ.
Girish, so you look like one office which is organized for meetings at home.
Oh, no. This is my kids' room. This is my kids' room. That's it. I have barged into.
Is your daughter back from Singapore?
Yeah. She completed her undergraduation.
Okay.
So she's actually joined data science in NYU. But this semester she is doing online. So she's going in January.
Okay.
Lot of meetings. I mean,
Okay.
They already had one part of the workshop at 2 o'clock, Ravi Shankar. ಇಲ್ಲ NTP-ದು 2 ಗಂಟೆಗೆ ಶುರು ಮಾಡಿದ್ರು ಅವರು. Day 1.
ಕೇಳಿಸುತ್ತಾನೆ ಮತ್ತೆ. Okay. Sure. No problem. So, sure. So we can start, Elijah. Okay. So basically,
Raghavendra, Dr. Sumita will just introduce it.
Sure. Okay.
Good evening and a very warm welcome to all our viewers this evening. On behalf of IIP Bangalore and IIP Karnataka, I welcome all our viewers and our faculty resource person for this evening. We have with us Dr. Raghavendra, a neurologist who has immense knowledge and interest in the field of epilepsy, specifically the surgical part of epilepsy. So he is here today to talk to us and share his knowledge on this very important and I would say a different method of approaching epilepsy. So without much ado, I do extend a hearty welcome to Dr. Raghavendra and thank you so much, sir, for taking time out to be with us today on behalf of IIP Bangalore and IIP Karnataka. I extend a very warm welcome and thank you very much for joining us. Over to you, sir.
Thank you very much for your kind information. I'll just introduce briefly. I'm a neurologist trained from Sri Chitra, and then I've done a clinical epilepsy fellowship at London, and I'm in charge of the epilepsy program for almost a decade now at Vikram. I'll just briefly touch upon some of the difficult parts of epilepsy which we face currently. And of late, there is a lot of interest in treating difficult epilepsies or refractory epilepsies, so what we call. So I'll just take you through a brief overview of what is epilepsy, how we identify some of the refractory patients, and few case-based experience has to tell what we can do. At least more than 60-65 patients, roughly I remember, which has been pediatric cases, which has been operated at Vikram over last many years. And I would say one of the most rewarding part of treatment, particularly is pediatric epilepsy, because it gives them a completely different perspective in terms of growth, development, seizure control, the family thing. Everything is much more different and very rewarding when compared to adults, actually. So coming to epilepsy, epilepsy is an abnormal paroxysmal neurological
Sorry,
state.
Dr. Raghavendra, can you make it a full screen? I think, is it a full screen? Yeah. Go to the, yeah, correct, better. Yeah.
Yeah, thanks. So basically, I just give you a brief overview. Like everybody knows what is an epilepsy. We all know what is a seizure. Seizure usually means one episode where there is an abnormal paroxysmal electrical discharge from the brain, whereas epilepsy means it is recurrent and tends to happen again and again. So when somebody has more than one seizure which is unprovoked and tends to have recurrent episodes, then you would call it an epilepsy. And then most of them do respond to medications. We have a small subset of patients who do not respond to medications, which you would call them as refractory medications. And these patients need a slightly different set of approach to treatment as to how you would manage it and how we actually make a proper diagnosis and what are the possible options which are there for these sort of patients. So globally, we have about 50 million people with epilepsy across, so it's a very common problem, very often under-recognized because the demands of the people are also, it's mostly people have a lot of social taboos and other issues that they don't come out in very open. And many of these patients actually live in resource-poor countries, so they have very limited access to much of the very advanced healthcare and also sometimes even to the basic healthcare. And about a third of medication, irrespective of what you do right from day one, whether you choose this medication A, B, C, over time tend to become refractory. And at least in India, about 5 lakh patients of these are expected to be those patients who may benefit from some sort of a surgical intervention to improve their epilepsy. So I'll just take you to a brief slide of idiopathic epilepsy just to highlight the pediatric age group, where you have one big bump of the incidence, which is much, and prevalence, which is much higher. Primarily, you may also see a lot of febrile seizures, benign Rolandic epilepsies, benign childhood epilepsies, many of them resolve, then idiopathic epilepsies, and then slightly better age in the middle. And then as we get older, the incidence gets to increase. So it's very important, and also there is a lot of problems where we start losing functionality, activities of living and everything. So epilepsy is a problem primarily with pediatrics, where you tend to deal with much more increased prevalence of epilepsy. At least a portion of them are actually who are not going to respond to medications. So the definition of refractory epilepsy, I personally feel, has evolved over many years. Although the first definition was you start treating them with 2 medications, first-line medications, which are most appropriate for them, and you are giving them in adequate doses, and then you decide whether the patient is responded to them or not to achieve a sustained seizure freedom. And if you are not able to achieve this adequate seizure freedom without any side effects, then you would perhaps call them as refractory epilepsy. However, with improved identification of several substrates in the brain, I would say somebody is only with 6 months of epilepsy or 8 months of epilepsy, but has a focal cortical dysplasia in brain, where there is a small lesion, you do an MRI, you see an abnormality in the brain, which we call as a dysplasia, and that patient has already tried, say, 2 medications, has daily seizures, is not responding, has significant disability because of it, then there is no point waiting for the definition to be completed. Here you are more or less sure that the patient is unlikely to respond to further manipulation with medication. You move forwards with further workup with regard to his refractory epilepsy. A very interesting slide which was borrowed many years ago from one of my colleagues with regard to a natural history of how epilepsy evolves. Basically, if somebody gets one seizure, you don't call them epilepsy, but a first seizure, then many of them, whether it is a generalized epilepsy, idiopathic epilepsy with some genetic basis, whether it is a focal epilepsy, whether it is in hemispheric epilepsy, they tend to develop refractory epilepsy where they stop medications over time. So once they are in early epilepsy, I would say about 60 to 70% of patients respond very well to one of the group first-line medications, which you may nowadays choose based on side effects rather than empiric like before, except for few contraindications. And then as you try, most of the patients do respond, but a portion of them do not respond to medication. Then you try doing multiple anti-epileptic medications and then move forwards with combination of medication. Again, by using multiple medications, say you use carbamazepine, lamotrigine, which have one mechanism of action on the sodium channel. Then you may try benzodiazepams or clobazam, which has a chloride channel mechanism, or levetiracetam, which is a presynaptic vacuole uptake inhibitor mechanism. So using different drugs, we can try a combo of medications, and in a portion of them, you actually start responding to medications. But still, remains a significant portion of patients, say about 20%, who do not respond to medications, where you have to intensely work with them with medications, or you need to seriously consider if a surgical option remains. So, why is it? Over time, from 2000, say 1980 onwards, there are so many medications which have come up, whether it is lamotrigine, felbamate, topiramate, phenytoin. So you have multiple medications. Despite the fact that you have so many medications, the incidence the prevalence of epilepsy, refractory epilepsy, more or less has remained the same. So definitely medications won't do the job in a percentage of patients where you need to seriously consider other options. So what are the other options you have is predominantly a surgical option. So just to compare the whole thing, there are randomized trials for surgery showing improved outcomes and better quality of life in temporal lobes. And many of these patients do benefit by an early surgical procedure than waiting for many years when they have a lot of social issues, secondary changes of atrophy in the brain. The epilepsy or a seizure onset zone, what we call from where the seizure comes, tends to be much more widespread, much more extensive. So they start having poorer outcomes with surgery. The best outcomes is an early reference so that we can plan it out early. So, Girish, you're able to hear me, no?
Yes.
Sure. So other problems which is often not discussed with patients is something called SUDEPs, which can vary with patients, but the fact remains that a lot of patients with refractory or drug-resistant epilepsies do have sudden unexplained death, which may also get better with once we have addressed their epilepsy problem in a more definitive way. And also, initially, most of the epilepsy centers and surgical centers were dealing with temporal lobe. So there is a significant experience with temporal lobe epilepsy, but of late they have recognized that more and more epilepsies tend to occur outside the temporal lobes, and reasonable good outcomes can also be attained in patients with extratemporal lobe epilepsies, but probably they need a little more extensive workup than patients with the clean temporal lobe epilepsy. So we have a wonderful
I think we lost you. Dr. Raghavendra? Yeah. Hello. Yeah, I'm calling him. Hello. I'm trying to call him.
Dr. Girish, what happened? He's not reachable? He's not reachable on the phone?
He's not answering the phone, but I called the hospital because he's in the hospital only.
Okay. Maybe some net issues there.
Yeah. Hello. Boss, we lost you. You. Long time, about 5 minutes ago. No. I think your connection is lost. No. Go back to 5 minutes. That where you were talking about that, where how many of them may need surgery, the medications, multiple medication graph. Oh no, that's why I sent.
I'm back.
Oh, network issue, I think. Yeah.
Well, I was happily lone going forward.
Yeah.
Okay.
You are here. Yeah. You are here. Yeah.
This slide?
Yes. Keep your phone on, Dr. Raghavendra, in case
Yeah. So basically what I was trying to tell is, this is a nice slide explaining us a natural history of epilepsy. So when I call first seizure, that's about 5% of population do develop first seizure somewhere at some point of time. I would say about 20% of these patients progress to have recurrent seizures and can develop epilepsy. So there are several markers to say whether the first seizure patient has a higher risk of developing epilepsy. Say somebody has a focal neurological deficit, a perinatal insult, a strong family history of seizures, an unprovoked seizure which presented as a status or a cluster in the first. These are all the patients who may develop epilepsy over the time. Certain markers to tell certain patients are at a higher risk. So once a patient goes into an early epilepsy, many of them do respond to a well-chosen anti-epileptic drug, which well-chosen anti-epileptic drug. It's about 65-70% of patients do respond very well to medication. Despite all your efforts and good medication, a combination of about further 20% require multiple newer anti-epileptic drugs. I would still say if you work intensively with them, you can get a significant control, but you may not actually get a complete seizure freedom. And in about 20% of patients, whatever you do, they tend to be refractory and they don't respond to medications. Some of them you need to continue trying modern anti-epileptic drugs, but most of them, a serious surgical workup is essential. So why is it? Maybe more drugs will do the job. So this is from 1990s onwards, if you see, so many drugs have come into the market, but more or less the persistence of refractory epilepsy has remained more or less same. So more drugs probably would not do the trick because it's more or less related at a tissue level or a substrate level where you need to do a little more management issues. So just to give you a brief thing, about 20% of patients with focal epilepsies or partial epilepsies tend to be medically refractory. They don't respond to medications. They have adverse effects of medications. And I would say, and randomized control studies, this was from my center where I did my training at that point, actually has shown the effectiveness of temporal lobe surgery in patients with temporal lobe epilepsies to improve seizure control and also quality of life. The most important thing to understand is we're all scared of surgery. All of us don't want to discuss that because it is, but the fact remains that if the patient remains refractory for many, many years and decades, they invariably have more areas of brain abnormality with seizure onset zone, and they tend to have poorer surgical outcomes. They may have more brain atrophy and more diffuse changes, which may be related to the epilepsy, medications, and a lot of intractable physiological changes in brain. So seizure begets seizures, what we say. An early reference into a serious surgical program often improves the planning for them. Another important thing which we often don't discuss with the patients is something called SUDEP, sudden unexplained death in epilepsies, which also improve with one's seizures are better controlled rather than not doing and continuing on multiple anti-epileptic medications. And previously, many centers have developed their first experiences with temporal lobe epilepsies. With a more and more MRI, we are also recognizing a widespread epilepsy right, from frontal lobes, parietal, what we call or parietal, most outside the temporal lobes, which initially was thought to have lesser postoperative outcomes because of the complexities of the brain network. But as we get more and more experience with them, with better imaging, we actually can get better outcomes. But these patients require perhaps a more extensive surgical workup when compared to these temporal lobe epilepsy patients. So, take you to the next slide. This is a very interesting, very proud paper for us because it has come from India, from All India Institute of Medical Science, one of a single central trial where about 116 pediatric age group patients were allocated into surgical versus medical therapy to see what happens to them. At 12 months, seizure freedom was occurred in the surgical group in about 77% of patients, while only 4% of patients with medical therapy have done well. So it does improve quality of life. So they had better quality, lesser severity of epilepsy, and more quality of life. So they can have neurological deficits which are anticipated and as planned and educated and done. So it's a proof that it works and improves quality of life in a significant portion. At least more than 60-70 patients have been operated at our center when the pediatric age group. When compared to adults, they are very rewarding because it improves their quality of life They start going back to school. They start performing well. There's a great degree of happiness and change in the family dynamics, which we have observed over last 10 years. So just to give a quick spin-off to the pediatricians, what are the epilepsies, what they deal with often, the febrile seizures is fine, but if you have atypical febrile seizures with brain scarring, focal abnormalities, we need to be careful that these patients may evolve as refractory epilepsies. You have absent seizures, which responds very well to valproic acid, but if you have myoclonic absences or any other things, they may have difficulty to treat. They may become refractory. They may need other sorts of management like ketogenic diet or a VNS or things like that. In general, majority of idiopathic epilepsies, say juvenile myoclonic epilepsy and other syndromes, respond very well, but a small portion of 5 to 10% patients don't respond well. Again, you may need dietary management, drug combinations, vagal nerve stimulator things, but there are few red flags in these patients when they become refractory. Benign Rolandic epilepsy is a very common problem what the pediatrician face, typically between 5 and 7 years of age. When they're going to sleep, you start seeing the parents come back to you and report they either have facial twitching, jaw twitching, or hand twitching, where they're unresponsive for some time, often in the first phase of sleep or when waking up from sleep. They do respond very well to medications and follow-up, or sometimes without medications. But a small portion of patients don't respond well, where you start thinking whether there is an underlying structural abnormality like a focal cortical dysplasia, which may be accounting for these atypical localization-related epilepsies, or say a child with a benign Rolandic epilepsy starts going down on then functionality. Then you do a overnight EEG and start looking for CSWS, where the EEG is full of ventricular spikes, which tells you that they need different line of management, maybe immunological management, high dose of benzodiazepams, valproic acid, levetiracetam. So they need different combinations. And a small portion of benign Rolandic epilepsy may evolve as Landau-Kleffner syndrome, where they have acquired aphasias, which mostly require immunological, more benzodiazepams and a medical management, at times a focal resection. So these are some of the typical unusual complex situations you may get into, but often what I meant, surgical management, I meant those children with refractory epilepsy, by definition, not responding to your first or second line drug, or where you believe putting more medication is not going to help, or those children with multilobar epilepsies, hemispheric epilepsies, or bihemispheric epilepsies, where you have failed with your medications, their epilepsy is affecting them. You need to do something more than what you can do with medications alone. So is there anything you can do to identify in your clinical practice an early case who may need further workup? The diagnosis itself gives you some clues. Suppose there is a normal child and then bang, he starts throwing seizure, which tends to be resistant. Mostly you might be dealing with a focal cortical dysplasia or some sort of a structural abnormality, which may be one of the hallmarks for further evolution to refractoriness. In a small portion of patients, you know the natural history, like a focal cortical dysplasia with focal epilepsies or say myoclonic absences, they tend to be refractory over time. You need to be careful while choosing their medications. And with clinical findings, somebody with a hemiparesis, with a focal neurological deficits, they tend to be much more difficult to treat than those patients who have a normal neurological examination. MRI is perhaps the most important tool which helps you tell what you are dealing with. Even if somebody has 3 seizures in, say, 2 months and you feel the drugs are working well, you do an MRI, you see a mesial temporal sclerosis, you see a focal cortical dysplasia, or you see a hemimegalencephaly, you know you are in trouble, because these patients, by natural history, tend to be much more resistant and may not respond to medications. There may be few electrographic markers which helps you tell. I just mentioned BLRE can be EEG, helps you make a right diagnosis. It helps you identify a idiopathic generalized epilepsy. It helps you identify a photosensitive response epilepsy. It helps you identify an absence epilepsy. It helps you identify a focal epilepsy, but it also makes you identify CSWS, LKS, and other forms which may make you alert as to decide on which way you would be heading with these patients, with more intense follow-up, more medications, and an early reference to a pediatric or an epilepsy neurologist for that. And family history, if there are multiple people in the family with neurological deficits and refractory epilepsy, they're all strong indicators that you may be dealing with some sort of a genetically prone refractory epilepsy syndromes. So what do we do by these surgical procedures? By common, grossly we can divide them as procedures which are intended to either control significantly or cure the patient, or there may be some procedures what we call as a palliative procedures where we are just tending to control or improve quality of life. Typically, if somebody has a normal child with refractory temporal lobe epilepsy, mesial temporal sclerosis, you do a temporal lobectomy. It is intended as a cure, a small focal cortical dysplasia with an intention to cure. But somebody is having drop attacks, bilateral scarring, you do a corpus callosotomy to prevent falls and injuries, or a VNS to prevent very refractory generalized epilepsies. We are basically looking at it as a palliative procedure to control and improve quality of life rather than with an intent to cure. So what do we do? So in your practice, you have seen some patients, you identified them, you got an EEG done, you have a syndromic classification, you put them on medications, it's not working. You made sure you have chosen the right medication. Suppose somebody has a juvenile myoclonic epilepsy, you put them on carbamazepine and change. It doesn't work. So you basically choose the right medications in the right doses, in the right combinations. In the right combination means adding oxcarbazepine to carbazepine or carbamazepine to lamotrigine, which are all sodium channel blockers, may not make sense. But if you add a sodium channel blocker like lamotrigine, carbamazepine, with a chloride channel blockers like clobazam, benzodiazepam, and with another mechanism like levetiracetam, which is a presynaptic vacuole uptake inhibitor. So this combination in a right, thoughtful way may actually be more sensible, where you have tried everything, the patient still gets seizure, you do further evaluation. How do we do it? So basically a good history. Suppose somebody, you first make sure you're not dealing with a seizure mimic. Many times the child comes to you with epilepsy in young age, less than 1, you do. It may just be an apprehensive parent that resolves some non-specific movement, tics, myoclonic jerks, pseudo seizures. They all can have, they can all mimic a refractoriness, what you can call it as pseudo refractoriness. So you take a proper history to make epilepsy by itself is very, very stereotypical. That means if I were to have epilepsy, say with temporal lobe, I get an epigastric aura, I get a feeling, then I have behavioral arrest, I have some oral automatisms. So generally I tend to do the same pattern. So I generally would not change the history. I would remain resistant, but not that tomorrow I have something starting from the right one leg, something starting from other. So any change in pattern, abrupt change who was responding to drugs has not suddenly started becoming unresponsive. If there are social issues, these may all be indicators for you to tell you may be dealing with non-epileptic events rather than an epileptic event. But coming back to epilepsy, you need to take a proper history which will help you localize from which part of epilepsy brain the epilepsy is coming. Somebody with a tongue, you look into the odor at the onset, he has twitching in the tongue, you know if it is from the inferior rolandic strip, but the EEG may show it somewhere else. So good history to tell you an aura from where it is starting, how the seizure evolves, what is the thing happening to the patient, how much he remembers, what are the relatives' history. And nowadays, with all the videos available, most of the patients would come to you with one video recording, which actually helps you identify what is happening to the patient. And once you know this, and then you do a proper neurological examination, say visual fields, which is often missed, focal deficits, lack of dexterity, which-handed they are. That also gives you a good, if somebody is left-handed, a whole family is right-handed, you can always look into a possibility of it being the change of the hemisphere, left hemisphere having a disease when compared otherwise. So a good examination, focal neurological deficits may all be indication from where the seizure onset is there when compared. So it is very important to have a proper examination. And perhaps the most important test, what we do is these two, the video EEG and the MRI. So what is a video EEG? A video EEG is a system where as you are aware, we put EEGs onto the skull, and there is a continuous time-blocked video recording which is happening simultaneously. How does it help? So from the EEG, you get intraictal discharges. You know where the epileptiform discharges are coming. It helps you. Suppose somebody has, we have some background recordings. So on the background, you see a very focal slowing in the right frontal lobe, and there are epileptic discharges coming from the right frontal lobe. That's an information on the EEG even before the patient has had a seizure. And as you record for a few days with probably planned taper of medications, he may get a seizure which is starting from right frontal lobe as behavioral arrest, left hand jerk, and things like that, which helps you tell it is a right frontal epilepsy. So by video EEG, what you actually see is what is the event patient is getting, a time-blocked EEG and an ECG, which tells you what is happening to the electrophysiology and the brain. And in between, when the patient is otherwise fine eating food, you get a lot of EEG things which tells you what is the background of it, what is the functional state of the brain, is it any abnormal electrical discharges, what we call as epileptiform discharges arising from here, which helps you classify and also localize the seizure onset zone or from which point the epilepsy is starting. And once you have this information, and the second most important information is the MRI of the brain, because when you have an electrophysiological and a clinical phenotype here with a structural assessment, previously we used to do all 1.5 Tesla MRIs. Now with more and more we are doing 3 Tesla, and several centers across the globe now do 7 Tesla MRI to look into more and more subtle abnormalities, what we were earlier considering as MRI negative, which evolved as subsequently becoming MRI positive things. Then you have a few more tests like a tractography, which is predominantly helps you see which way the white fibers are organized, up to down, right to left, front to back, to help you understand the structural organization of brain. Then there is MR spectroscopy, which helps you understand the chemical structures. I would say still of lesser use. But then you have functional MRI, which is a tool to help you identify the language areas, the hand areas, the memory organization as basic tools when you are doing these sorts of testing. Irrespective of all this, a small portion of people, you may have discordant data. That means the epileptic discharges may be from one area, the clinical pattern may be from slightly different area, the radiological abnormality, the PET spec or the functional studies may be slightly different. So when you're not sure, you may need a little more information. If it is especially coming from midline, hiding part of the brain, like say cingulate, subcortical structures, orbitofrontal structures, or say, so it may not be very easy to capture these abnormalities on EEG from the surface. So you may sometimes need to put electrodes into the skull to localize these abnormalities and then decide on one localization from where the seizures are coming, and also to decide the margins and the safety of the surgical procedure. And in this situation, when the electrodes are sitting inside the skull, we can stimulate them at varying stimulation parameters, either physiological as 1 Hz and 50 Hz. I mean, it's little out of the context for this, but we can use it to localize the functionality of the brain. So how do we select the possible surgical candidate? So once we do these things, first we should be sure that we are dealing with a refractory epilepsy, not pseudo-refractoriness, not non-epilepsy, patient has not been. So you make sure you are dealing with a medically refractory patient. You have the EEG, the video EEG, that is the clinical part, the EEG part, the imaging part, all suggest to a possible focal epilepsy, which can be addressed surgically. The surgery should not be, it should be acceptable from the physician point of view that it is not worse than the disease itself. It should have a reasonable chance of improving a quality of life. The patient and family should have an acceptability to this procedure. So these are important criteria for us to move forwards. And then, as I told you, this is just a history which helps you what type of and why you're refractoriness. This is just a slide. Interesting, like if you carefully see, there is a right facial contraction, right hand contraction, which tells it's from the left front brain. This is a typical figure of 4 contraction, which tells it's right prefrontal seizure. This is a kicking epilepsy from an orbitofrontal or a cingulate hypermotor seizure where the patient in sleep may get up and kick and roam around. This is a child who would have paresthesias, predominantly eating epilepsy, would have paresthesias with a head drop. This is what you call as a Jacksonian march, where it starts from inferior Atlantic area where he's trying to hold his chin, the head is jerking to the left, then you would have left focal seizure. So these are all clinical findings which you get during video EEG, which helps you basically localize and identify from which part of the brain the seizure may be originating. So as I told you, you get EEG abnormalities, which helps you. I just need to jump this slide. Just 1 minute. You're able to see the slide? See, 1 second. Right. 1 second, Girish.
Yes, yes, yeah.
Okay.
You have to go to the presentation.
Minimize it. Okay, just open it again. I don't want it on the hold my 1 second.
The presentation mode go in Microsoft PowerPoint. Yeah.
Okay, sir. No, I was just, there was one, you're not on the, I don't want presentation. Yeah. I don't want patient. 1 second, I'm just.
Sure.
Just that patients, I felt little bit of identity issues, so just rectifying it. Okay. Here's what I can do. Okay. Yeah, just black. You are getting it, no? So basically, this is the usual EEG what we use.
Make it into presentation mode, Dr. Ravindra.
Yeah.
Big screen. Yeah. This fine. Yeah.
The typical absence spike, just to. So I would say this is perhaps for epilepsy. This is the most important evolution which has happened. So typically, what happens when a physician sends us cases? There may be MRIs which is a good screening, and when they come, we may again ask for a repeat MRI, and the pediatricians may be wondering what these guys are up to. So basically, why is because a volumetric MRI we do, basically it is a complete 3D acquisition. There are certain things which we want to do with the sequences. It's a volumetric T1, T2 gradient sequences, which help you identify very subtle abnormalities, which are dedicated epilepsy protocols, which can be missed on a regular MRI. And sometimes you may add new tools to it. So this is a typical example. This is how a 1.5 Tesla MRI would look for you. You would think this looks okay. This may be a little fudged. Otherwise, you may pass it as normal. I mean, you won't pass it, but definitely this becomes more obvious on a 3 Tesla MRI, which nowadays more or less we are asking or doing it for more patients. So if you see, this is the white matter, this is the hippocampus, this is the amygdala anterior, there's a temporal lobe with the gray-white. And if you see here, it's a complete abnormal malformation, which you can't. So there is a clear-cut increasing magnetic field, improves resolution, and also pick up of these abnormalities. So this is one of our cases where you can see this hemisphere is normal, but if you see this hemisphere, it is big. There is still myelination. The gray-white matters are not so great. The typical MRI of a hemimegalencephaly, and if you do a gradient image and a tractography, you can see the posterior part of the brain seem to be much more affected than the anterior part. So this is an imaging. The moment you see this, irrespective of the history, how much early, how bad, you know that you're likely more or less going to deal with a child who is going to develop refractory epilepsy in due course of time. So this is another MRI which is from 1.5 Tesla. This is the temporal abnormality which showed a cortical dysplasia, and this is post resection. And the same one on 7 Tesla, if you were to see, this is gray matter. This is white matter, which is very clearly discernible. You can see it's normal, but if you go on this side, you can't identify the way you can see the white matter and gray matter on this. So these are things. This is a patient having cortical dysplasia. As you increase the magnetic field, you are likely to catch more of these things. But then telling this, just taking a 7 Tesla wouldn't suffice, because you need a video EEG, you need an intracranial abnormalities, you need to have an hypothesis, and then you stare in that area and be careful and start identifying these structures. Again, another patient with a 7 Tesla. If you see, we don't have 7 Tesla in India for now, but I mean, some of the demands probably I think they're getting. But generally in clinical practice, 3 Tesla, but there's a 1.5 Tesla. But as you increase magnetic field, you try to get and capture subtle abnormalities. So another test is a PET. PET is a functional assessment. So you have an electrophysiological data which is intracranial. We have an electrophysiological data which comes on the EEG when the child is developing seizure, and you have a structural data which is coming from an MRI, which improves with higher resolution. Then now you have the physiological data, again, where you do a FTG PET, where you give glucose, and you have other metabolites which can be used, but often in Bangalore and other places we do a FTG PET. You give glucose, it goes and gets deposited in the brain, and if depending on how the brain is using the glucose, if it is not healthy, you'll have areas of focal abnormalities. So when you are not sure if the MRI is abnormal, the PET scan usually helps you go and tell you, look, this is the abnormality, you need to redo things. So again, this is one of our old patients which was published who had a posterior quadrant disconnection. She used to have eye deviation to one side and daily seizures and often clusters. This is, I'm not sure the video is because of the privacy obviously, but if you see that during the seizures, this first 4 lines are the left, these first 4 lines are the right, this next 4 lines are the left temporal, right occipital. If you carefully see on the right posterior head region, you can see these sharp electrical discharges evolving at onset. Then it is slowing down to, this is 1 second, so slowing down to theta rhythm. So you would call this as right posterior head region, an alpha rhythm, right posterior head region seizure. If you see carefully, the left temporal lobe, left posterior head region looks good. The gray matter is fine, the white matter is fine, gray-white differentiation is fine. But on the right side, if you were to see, you can't differentiate between gray matter, you can't differentiate it from white matter. It is just a plaque of tissue, which is called a posterior quadrant dysplasia. Girish, you can tell me whenever I'm finished with my time. My last 10 minutes, I can finish any time. I'm just going on case based now.
It should be okay, right, Ravi?
Yes, sir. You can finish in 10 minutes. No problem. Thank you.
Okay, sure.
Sure. So if you were to see, this is what we call as a focal cortical dysplasia. This child, as I mentioned to you, has refractory epilepsy. You know this child will have refractory epilepsy because of the anatomical substrate. You have an electrophysiological substrate where the spikes were there from there, the seizures were there from the same area. So you have a structural correlate, you have an electrophysiological correlate, and this child had a PET scan, intracranial PET scan. Actually, the patient was initially had a seizure while waiting, so immediately it was given. So this is called ictal PET, this is called intrictal PET. So when there is no seizure from this area takes less glucose, it is hypometabolic and it is abnormal. And now during the seizure, it becomes hyper, taking up the increased glucose. The patient underwent a posterior quadrant, has been doing well. So basically what it tells you is how to do all the three things together and plan a procedure. Another test, the problem with PET is you have about 100 minutes, you have to go there, you have to finish, it's expensive, but advantage is it has a very good spatial resolution like this. Another test which is often done is something called SPECT study, where sometimes if you're not sure, during the seizure, a technetium radionucleotide is given as IV, and as it goes, and during the seizure, so patient is on a video EEG room, patient is being recorded, and once the patient indicates either an aura or a seizure, the radionucleotide is injected. Earlier the better, because it takes about 10 seconds from the hand to reach the brain, and as soon as it reaches the brain, it helps you identify certain areas in the brain which are abnormal. For example, this is an intrictal SPECT where patient was not having seizure. You can see the glucose uptake, the radionucleotide uptake. It was less here, suggesting this is deceased. The same one, when the patient is having seizure, is actually this area has taken more glucose, telling that this is the area from where the seizure is coming. So this is another tool we can subtract from each other, do a little more post-processing and help identify from which part of brain the seizures are coming. Again, you can use these tools to improve your surgical outcomes. So this is the seizure from where it has started. It has moved to one path. So when you are doing a surgery, you should not only involve this, but also the neck. So this is how it is done. I will just touch upon the functional MRI. Once you have evaluated all the patient, you have decided that this is a surgical patient, sometimes you need to know where is the hand area, where is the leg area, where is the language area. So this is what we do in a functional MRI. So what we do is a block design in our place. Basically what happens is, suppose I want to move my right hand, I start doing contraction, relaxation, my left Rolandic strip gets more blood flow and it starts functioning. But the amount of blood flow is probably many, many times more than what is actually required. So this activated brings in changes in the blood flow, brings in some amount of paramagnetic changes, which can be determined by a functional tool, which can then be put onto a structural imaging, and we can actually tell from where, which part of the brain had those circulatory changes. So I put the patient in MRI. I record first a T1 or a FLAIR sequence, which is a 3D volumetric sequence, and the patient should not move. So the patient should be aware of what he's doing. He should be cooperative and not moving. So when he's doing, I say, okay, start moving your hand. He starts doing, say, 10 seconds is my block diagram, and then next 10 seconds I stop. Again 10 seconds he does, again stops. So I do where the blood flow is changing, I statistically localize and then put it onto the structural imaging. So it helps you identify motor areas, language areas, and also it helps us predict post-operative changes. And following with some of them, we can actually, this is one of our patients who had a language fMRI done, which was bilateral. Then you can also do a tractography to decide how deep and where the surgeon's line of incision and everything. So it helps you with surgical planning. Just few more cases. This is a 16-year-old girl with refractory left temporal epilepsy. The moment you see her MRI, here you see it's a gray matter. She has failed 2 drugs, she is white matter. But if you see here, it is a full chunk of tissue without clear categorization of gray-white. So this is a patient who won't respond to medication, would need surgical resection of these abnormal structures, one to improve her seizure control, reduce her medication, and also protect the other areas of brain from a sustained attack from this area in terms of epilepsy. Then a 14-year-old is one of my best patients. She has now graduated, doing very well for last 4 or 5 years now. She had a right, if you see the left is fine, the right is abnormal, with the right mesial temporal sclerosis, with the right temporopolar abnormality. The patient had a clear aura fear. So she gets fear, it is amygdala or anterior temporal, mesial temporal. They record the seizures. Seizures were coming from here, electrical abnormalities from here. We do a neuropsychology testing just to see how all the different parts of brain are working. That showed that patient had a mild non-verbal dysfunction. That means it is a right temporal dysfunction. So we had electrical abnormality, radiological abnormality, clinical abnormality, and a neuropsychology abnormality. She underwent a right temporal lobectomy 5 years ago, and she has finished her graduation. This is one of the other child who had have a focal seizure affecting the left leg. He used to get 20-25 seizures a day. If MRIs were previously multiple times interpreted as normal. So when they came to us, we recorded the seizures. Seizures were all from the left, involving the left motor seizures, starting from the left hand. If you see the EEG, this is in between the EEG showing slowing. These are abnormalities, electrical abnormalities from the right side. That is this portion. And now this is during the seizure, you can see seizures arising from the right motor slip. So we recognized, going back with a good, correct sequence of MRI, that there was a focal cortical dysplasia here. And then we did a PET scan which corroborated to that. So basically, he underwent a functional MRI which didn't show much activation on this side, and we removed up to 1/3 of lower Rolandic areas can be removed safely. And he is probably now 8 years into follow-up. He is actually one of the rankers in the school, doing very well from refractive multiple seizures daily. So I'll just jump this slide. It's not required. This is one of the other children. Just to tell you, generally the moment we as pediatricians see refractory epilepsy with perinatal insult, we start thinking of bihemispheric epilepsy. This was an 8-year-old girl with history of perinatal insult with a normal IQ. All her seizures would start as visual hallucinations. The moment you have visual hallucination, we know it is coming from the occipital lobe. MRI showed left occipital posterior temporal gliosis. So you can see this is all gliosed, but the other hemisphere is intact. So when some of them with perinatal birth insults, strokes are still surgical candidates, we did a functional MRI to show where her visual cortex was, where her language was, which had moved to the other side. She underwent a posterior quadrant disconnection with almost no seizure for many, many years. Now she is into college. So somebody was having multiple daily seizures, post-surgery, almost seizure-free now, and also improved quality of life. This is another patient with a focal cortical dysplasia just abutting the motor strip. This is a functional MRI showing the hand area. This is the tractography telling the surgeon not to go deep, but only restrict the resection to this. With an awake surgery, you can do these procedures, and this is the post-op resection, and he's seizure-free. He was an orphan. He's seizure-free for almost like 4 or 5 years now, with no fresh or any other neurological deficits. So this is one last patient I will tell you. He had a gliosis. He had a perinatal insult at the age of 3 months. He had a scar. Then he started developing daily multiple seizures with falls. And we recorded the seizures arising from the scar area. This is one of the neurosonogram which helps you identify the structure. And this is the intraoperative where the scar was. And all the scar tissue was removed. And he is 5 years seizure-free. He's going to college now. So these are children who are otherwise, this was an awake surgery. I had to have a very good rapport with the child because of and he did an awake surgery at the end of it. Sometimes, I'll just tell you one last case, you might need to put electrodes into the skull. This is an 8-year-old boy with refractory seizures, predominantly nocturnal seizures. Initially, it was thought to be benign Rolandic epilepsy. His seizures were not controlled, and he came to us. His symptom was he used to get vague tingling symptoms of the left temporal region, and then he would have an asymmetric tonic-clonic seizures. Just down here. I want it as presentation. One second, just put on. And the 2 slides I want to show. I'm almost done. You're a
Make it presentation.
Yeah. Oh, yeah. So this is a boy. I think Girish knows this boy. He's about 8 years old. Daily seizures, Rolandic epilepsy. Everything is Rolandic epilepsy. He goes to sleep. It is right parietal seizure. EEG right parietal. But then, if you carefully see, there was an abnormal sulcus in the brain going up. Otherwise, nothing. But when I do a high resolution MRI, this is a tail here, which is suspicious of a focal cortical dysplasia. I did a PET scan. If you see PET scan in this area, this gyrus was not taking glucose. So what does it mean? This boy has a focal cortical dysplasia, daily seizures, 3 drugs. He is not going to respond to medications. So he actually underwent surgical resection of gyrus and is now seizure free and doing well. And this otherwise would not become seizure free at all. Sometimes, as I mentioned to you, this is a patient with 4.5 years old with refractory seizures. We did his video EEG, asymmetric tonic seizures, suggesting that it was coming from the right brain. His MRI was interpreted as normal, but EEG clearly showed it was coming from the right brain. And multiple drugs had failed. We did an MRI which showed an abnormal sulcus in the brain from the right side. We did a PET scan which showed that this area was hypermetabolic and also the insula was hypometabolic. So these are electrodes which are put into the skull, and once you put into the skull, you start seeing that they are all focal seizures which are arising from one portion of the brain, and these are all seizures coming from this abnormal sulcus. So he underwent that sulcus resection. It was a focal cortical dysplasia, 5 years, grade 1 seizure outcome, and he is seizure free. And just to complete, this is a MRI with hemimegalencephaly, normal brain, abnormal brain with refractory seizures from the left hemisphere. So these patients require more widespread surgeries with hemispherotomy. Patient had a right-sided weakness, but progressively with physiotherapy became independent, going to school, from daily seizures to independent life, but with neurological deficits. If you try to avoid it, you know that this hemisphere will keep on having seizures throughout life, almost daily, multiple times in a day, and affect the quality of life otherwise. Another common problem which pediatricians face, tuberous sclerosis, where you have multiple tubers with refractory epilepsy. You don't know from where it is coming. We do video EEG, identify those tubers which may be abnormal. This is one of my patients where we ended up putting electrodes into each of the tubers and record the seizure. Most often it is 1 or 2 tubers which may produce the seizures, which can be resected to have improved quality of life. Sometimes they tend to come back with more seizures, so you need to have improved quality of life for them. So coming back, the gist of the lecture today was to identify those patients with early identification of patients who are refractory by history, by examination, by a good MRI and a good EEG, and an early referral to see if a surgical algorithm can be evolved to make sure that seizure outcome can be improved. There is substantial availability of literature already in the field to make us clearly understand that this procedure is beneficial to these patients. I hope we all identify these subsets and put them in the right path of clinical practice. Telling that, I thank the organizer and Girish and Indian Bangalore Pediatric Association to give me an opportunity to speak on your esteemed forum. Thank you very much. I'm happy to take questions now.
Thank you so much for a wonderful elucidation of a topic which is probably fairly new to a lot of pediatricians. I have just one question, Doctor. The post-op, is there any requirement for any anti-epileptics?
Yeah, I'll give you a few different situations. Suppose that girl whom I told with a right temporal lobectomy, she would not require medications at some point of time. So all these things will be determined by what was your data prior. The boy whom I told you with a simple Rolandic seizure had a clear-cut one gyrus which was abnormal. In the surgery, we could safely, clearly remove the whole gyrus, gyrectomy. So it is a gyrus to gyrus resection in focal cortical dysplasia. Almost invariably, he would not need medications. Suppose if your resection has been incomplete. So many times in adults, what happens is you have one-sided dominant, but by 10 years, 20 years, the opposite temporal lobe epilepsy, you have more widespread abnormality or a hemispheric abnormality. Then you would continue them on medication because you have only attended to generator 1, and there are very other subtle abnormalities, either by clinical examination or by EEG or by somebody has a lot of status. I would probably leave them on smaller doses of medication. So the comfort zone depends on what you have addressed, whether you have removed everything or you have not really gotten into it.
Okay. Thank you very much. I'm sure there will be a lot of interest generated, and probably there will be a lot of pediatricians who will reach out to you. So probably we would need to take your email and then, post it on our group so that anybody wanting to reach out to you could probably do so. And I don't think there are any other questions. Dr. Avishankar, anything? You are muted.
You're muted, Ravi.
No, sir, not yet.
He's on a membership drive, it looks like, huh?
2016, I think I had done a talk in Sure. Thank you so much.
Thank you very much. Dr. Avishankar, any closing remarks?
Hey, thank you very much. Thanks a lot. Dr. Raghavendra is a very hardworking neurologist. I mean, he sometimes dedicates 3-4 hours to the patient. So, yeah.
Thank you very much, sir, for taking time out. On behalf of IAP Bangalore, thank you very much, sir.
Thank you so much.
Thanks a lot.
Thank you to all our viewers who have joined us this evening. Thank you very much. Good night.